Asthma for many years has been considered to be a one-phase disease, and we soon now realize that it is not. Patients with asthma may present with different symptoms. They may respond to different medication differently. We know that the airway inflammation in the disease is different. The drivers of the inflammation are different. So that is why precision medicine is an important initiative in this disease, as it is with others, so that we can pick the right treatment for the right patient. One of the very important findings in asthma, looking at the mechanism of the disease, is that it is driven by multiple inflammatory cells, multiple cascades of cytokines and chemokines. The two big buckets of drivers of asthma are what we call T2 asthma, T2 high asthma, and the other one is T2 low asthma. And then there are biomarkers for both pathways. Unfortunately, most of the biomarkers right now available reflect T2 high asthma. These include blood eosinophils, exhaled nitric oxide, sputum eosinophils, and there are some research biomarkers like serum periostin. So really, at this point, these are the biomarkers that are available or have been utilized in the clinic, but also in clinical research. We have no biomarkers that reflect T2 low asthma, which are desperately needed. Biomarkers have to have important characteristics. One is they have to be reproducible, they have to be easily measured, they should have a predictive characteristic, meaning they should predict who's going to respond to that medicine and who's not. But also biomarkers should have some prognostic effect. So meaning if I see a patient and the patient has very high blood eosinophils, that high blood eosinophil level is a good biomarker to reflect not only response to certain treatments like inhaled steroids or anti-IL-5 drugs, but also can also predict prognosis, such as increased risk of exacerbation. Finally, good biomarkers should reflect response to treatment. So what we call pharmacodynamic biomarkers, meaning the levels of biomarkers would go down with therapy. So in clinical trials, many of these biomarkers have been used to predict patients who may respond to certain biologics or targeted therapies. For example, in our studies with omalizumab, which is an anti-IgE, we found that patients with high blood eosinophils at baseline or high exhaled nitric oxide have a better response to anti-IgE therapy. Very similar in studies on anti-IL-5 therapy, they showed that the higher the blood eosinophil levels at baseline, the better response to management with anti-IL-5. Other clinical trials looked at serum periostin, which is a serum biomarker that reflects T2 activity, particularly IL-13 pathway inflammation. And those studies found that response to IL-13 targeting drugs is affected with serum periostin at baseline. The higher the serum periostin, the better response to such therapy. So these are some examples where biomarkers have been utilized in the clinical trials, and hopefully some of these may be utilized in the clinic.